Twitter feed. Lots of good stuff going on there. Use the hashtag Gutsy Learning Series 2014. And during the break, we're going to we'll run the Twitter feed on our screen here in the room. We're going to move on now to our next presenter, who is Dr. John Marshall. Dr. Marshall is a professor of medicine at McMaster University and an active consultant gastroenterologist at Hamilton Health Sciences. After completing his BA and his MD at Queen's University, he undertook his residency training and Masters of Science in Clinical Epidemiology and Biostatics here at McMaster University. He is now the director of the training program in adult gastroenterology. He is the head of clinical research for the Division of Gastroenterology at the Farncombe Family Digestive Health Research Institute. Dr. Marshall has held a Clinician Scientist Award from the Canadian Institutes of Health Research and has received peer-reviewed research funding from several agencies, including Crohn's and Colitis Canada. And he also sits on our Scientific and Medical Advisory Council at Crohn's and Colitis Canada. So we're delighted to have him speak as well. And he is here tonight to talk about new treatment options and access in the management of Crohn's and colitis. So please help me welcome Dr. Marshall.
Great. Well, thanks very much for that introduction, and welcome everybody. This is exciting to have so many people here, and also even more people online. I think Dr. Reinisch is actually a brand new Canadian, and he's just timed it perfectly, finishing his talk for the puck drop in the Leafs game. So I think he's actually planning to sneak out and catch the first period. Treatment in Crohn's and colitis. Have to click through this. There we go. Okay. There we go. There's me. Okay. Dr. Reinisch has just made for you. The first is that IBD is very common in Canada, and as he's stated, we are considered a hot spot, and it's not really a claim to fame that we'd like to possess, but that's the fact. So 1 in 150 Canadians is actually afflicted by inflammatory bowel disease, and we get 10,000 new diagnoses across Canada every year, which is really a huge number. But this has a big burden. This is a huge cost. We think about how much our society pays for this. Direct costs are what you pay for treatment and hospitalizations, and doctors and nurses. Indirect costs, which are even more, what gets lost to the economy because people with Crohn's and colitis don't go to school, they don't perhaps aren't as productive at work when their symptoms are active. So altogether, inflammatory bowel disease is a very expensive thing for the Canadian economy. And it's, I think, important to recognize that Crohn's and colitis are really conditions of the 20th century. If you go back 100 years, these were rare diagnoses, but something happened in our environment or in our lifestyle in the middle of the 20th century that suddenly created this growth of inflammatory bowel disease, both Crohn's disease and ulcerative colitis. A lot of speculation as to what that change in the environment might be, but it's something to do with our modern lifestyle, our Western lifestyle. Perhaps it's because we're also clean. There's a strong hygiene hypothesis out there that might explain this, but none of this is really proven. But we just know that this is a relatively recent phenomenon. And one of the reasons why Crohn's disease and ulcerative colitis are expensive to our economy, and tragic in a way too, is that they affect people at a very critical age. So the peak age of onset of Crohn's disease and colitis is in fact in people's 20s. And, but there's a spectrum from infancy to a very advanced age when people can show up for the first time with Crohn's disease or ulcerative colitis. But as many of you know all too well, when this sort of thing strikes you as a teenager or a young adult, it has a huge effect potentially on things like your education, the relationships you form, starting families, starting jobs, and succeeding in those jobs. And so if not treated well at an early stage, it can have really significant downstream consequences. So we have to treat this condition better. So this is, you can quote me today, but I say this often, and it's true, there's never been a better time in history to have inflammatory bowel disease. And I think at the end of the day, there's some cause for optimism, even though a lot of people are clearly still suffering with these diagnoses. I think there is some good news on the horizon. There's a lot more we need to do, but I think there's some positivity in the modern era. And well, I think we do have some better understanding of maybe not the single cause of inflammatory bowel disease, but we know a little bit more about what kinds of things go wrong when people develop inflammatory bowel disease. So we still don't have a cure, but I think we've got some exciting new targets for treatment. And the kind of research that Dr. Reinisch spoke to you about is the kind of thing that can target some of these new opportunities. As we learn something more about what might go wrong in people with Crohn's or colitis, we can try to reverse that with the treatment. So we understand, I think, a little bit more about the natural history of Crohn's and colitis. We don't so much focus in the moment and trying to make people feel better. I think as clinicians and the whole healthcare team, I think we're much more aware of the whole landscape of Crohn's and colitis. So we're thinking more of the far horizon, what might happen to people with Crohn's and colitis, and our eyes really on that horizon and trying to make sure that they have a long and productive life. We have some better tools for tracking Crohn's and colitis. Dr. Reinisch referred to fecal calprotectin, which is, for us, a relatively new stool test that can help to measure how active Crohn's and colitis is. That's just one example. So we have better ways of keeping track of people. We do have therapies. We certainly need more options, but we have more than we did 10 or 20 years ago, and that's a very positive thing. I think the last point is very critical as well. I hope that we have a bit more of a holistic approach to health maintenance in inflammatory bowel disease, not just focused on medication, but medication is very important, but also looking at all aspects of health. And I think over the last few years there's been a lot more attention to this general health care of people with Crohn's and colitis. And I should also mention on this slide that we have great support from a number of wonderful groups, including Crohn's and Colitis Canada. I think those resources in the community have grown and improved over the years, and I think many of you have benefited from them. So just briefly, this is what causes inflammatory bowel disease. Well, there's no single thing, but the bottom line is that this is an overactive immune response to some trigger in the environment. Something turns our immune systems on, and that immune system attacks the bowel, and it causes a lot of damage, a lot of reaction. And the problem with people with Crohn's and colitis is that they can't turn it off. So where someone else might develop a little bit of a reaction to something, deal with it, and then the immune system calms down again, it seems people with Crohn's and colitis can't calm it down after they have that initial reaction, and that's what spirals out of control. We don't put you at risk if you have a twin with Crohn's or colitis. You're more likely to have it yourself, but that's not the only thing. And obviously our genes didn't change in the middle of the last century. Something in the environment did. So there's a real hunt to figure out what in our environment changed. And as was already mentioned, the big frontier, I think the exciting frontier of the current decade, perhaps the current century, is exploring all our bacteria, so what we call the microbiome. Microbiome is the term we use to describe all bacteria that are in our bowel, on our skin, in our mouths. Altogether, we think those bacteria probably play an important role, and among all those bacteria might be the trigger that we're looking for. So, human microbiome, that word, you just need to know the cocktail party trivia on the top left, that you have 10 trillion cells in your body, but there are 100 trillion bacteria in you, so you're outnumbered 10 to 1. And until the last recent years, that's been largely ignored. The bacteria in our bowel thought to be kind of nuisances in a way. But I think now we realize they really are part of us. Our body talks to the bacteria talk to our body, and we think they play an important role. So is focused there. And I'll just mention quickly, as was already mentioned, that we are participating in the GEM project, and please, if you haven't signed up for this, you can look at the website and learn about it. And Zach Muqtadir, our research coordinator, is actually here at the back, and he'd be delighted to speak with you on the way out if you want to learn more and even participate. So I mentioned we know about how these conditions progress, and this is a figure that often gets shown at medical meetings because it captures a lot of what we're thinking now. We used to focus a lot more on symptoms. So if you feel good, we're happy. If you don't feel good, we try to get you feeling good. But we used to focus mostly on the symptoms day to day. What we've realized is those symptoms come and go. The activity of Crohn's and colitis comes and goes. It flares up and it goes away. But every time it goes through a phase of being active, it can cause a little bit of damage. You get a little bit of scarring. And over time, as it comes and goes, you build up this damage. And it's that damage, we think, that ultimately leads to problems like blockages. It can need surgery, maybe even fistulas, those tunnels that can form in Crohn's disease. And in some unfortunate people, even cancer that can be related to long-standing Crohn's and colitis. So with that concept, we're much more keen to recognize the disease early, try to treat it early, and try to get it under control early, and follow people closely to keep it under control, because we recognize that that damage that builds up over time can be a real problem. So this is, I think, captures really our change over time. I graduated from high school in 1985. So different era. Rubik cubes, Duran, big hair. You remember all that. And, well, maybe you don't. Actually, many of you probably don't. But, you know, it was a superficial age. We're much more focused on relieving symptoms, which is kind of where we started 30 years ago, I think. You know, but as we went through time, we realized it became important to not only treat symptoms, but to avoid or limit some kinds of treatment. And we really focused still on trying to limit our patients' exposure to steroids. Sometimes we need them, but we don't like to treat people with steroids for long periods of time. We, I think, began to focus on trying to avoid surgery. Surgery is often necessary, and it's not always a bad thing, but we try to limit the number of people who need surgery, and we certainly don't want to see people in 2014 requiring repeated surgeries. As was mentioned already, we then realized that a big way to prevent surgery is to make sure that we actually heal the gut. So we don't just focus on how you feel. We're looking inside maybe a little more than we used to. And I know you don't like that, but there's good reason, because we want to make sure that the lining of the bowel is actually healed, because that may be a good predictor of keeping disease under control and avoiding surgery. I think if we do it, we think we can limit disability, so we can keep people working, and ultimately the goal in 2014 is to give our patients a normal quality of life. And that's a very much an attainable goal in 2014 if we follow people well and closely from the beginning. So normal quality of life is really where we want to go. So what treatments do we have? I'm just going to go quickly through the kinds of treatments that we have available. And for many of you, these may be all too familiar, but this is our menu. And it's not a long menu, and that's part of the problem. We'd like to have a multi-page menu that we can flip through, but we're limited to the options really on this page. So we have what we call the 5-ASA drugs. Sulfasalazine would be included there. We'll talk a little bit about that. I won't talk much about antibiotics, but we do use antibiotics, often ciprofloxacin, metronidazole, ciproflagyl, very common antibiotics used for specific scenarios. We still do sometimes need to use steroids. We love them and we hate them because they have some negative side effects that we would like to avoid. We have treatments we call immunomodulators or immunosuppressives we'll talk about. And really the excitement over the last decade has been with what we call biologics. And some examples are listed here, and we'll talk a little bit about them as well. So 5 different brands of 5-ASA. You may recognize some of these names if you've been on these treatments. These are all derivatives of a grandfather drug called sulfasalazine, which is 5-ASA attached to something called sulfa. Now, in Crohn's disease, we've moved away from these drugs. A lot of people are still using them. They're very benign medications. They don't really cause much in the way of side effects, which is good, but they don't seem to be that effective in people with Crohn's disease, with the possible exception of the old one called sulfasalazine. But in colitis, ulcerative colitis, these drugs are still the workhorse of treatment. So most people with ulcerative colitis are on one of these medications, I would say. They can be given as pills, but colitis, where colitis happens, so we can give them the other way as well to go straight to where the disease is. So certainly as suppositories and enemas as well, we can give 5-ASA. And a little change in our treatment over the last few years has been, we used to give these pills several times a day. We've actually realized that in most scenarios, we can probably just give them all once a day, which is easier on patients and better for compliance. A little harder to forget when it's only once a day. And they may help to prevent cancer. That's a very controversial thing which we can talk about later, but there is some evidence to suggest that people on 5-ASA might have a lower risk of colon cancer, which is another good thing, obviously. Okay, that's 5-ASA. A class of traditional drugs is steroids. They're not this kind. You're not going to get strong taking these kinds of steroids. In fact, they have more negative effects than positive, certainly. Prednisone is the name probably familiar to many people. There's another steroid called budesonide, which is a little less potent and probably has far fewer side effects, but it's not as strong. The nice thing about prednisone is it's been around forever. It's dirt cheap. Usually the dispensing fee to the pharmacist is more than the actual cost of the medication. But because of the side effects, we try to use them judiciously when we have to, but we don't use them for long, and we certainly don't like people to be on long-term steroids. That's something we really try to avoid. There's a lot of side effects, and anyone who's been on steroids will have experienced many of these and will have complained about these. Fluid retention, mood disturbances, If you're prone to things like acne, diabetes, blood pressure problems, it can make those worse. And it can also contribute to problems with the bones, including osteoporosis. So we try to limit use of steroids. And that's why we really try to look for what we call steroid-sparing alternatives. So when people require steroids, yes, okay, we may have to treat you with steroids, but we're already thinking of what we're going to use as a longer-term treatment so we don't have to use them again. That's really where we go next when we give someone steroids. So that gets in another category of treatment, what we call the immunosuppressives or immunomodulators. We call these drugs immunosuppressives, but I'd really say that all medical treatments for Crohn's and colitis really suppress different parts of the immune system, because the problem is that the immune system is overactive. It's attacking the body inappropriately. So we try to dial down little parts of the immune system so that the bowel doesn't get so inflamed. So immunosuppressive treatments, these ones I've listed here, are really long-term treatments that we use to try to steroid spare, that is, avoid having to use steroids again. But we can use them alone, or we often use them now together with the next category, which is biologics. So a lot of people on biologics will also be on one of these medications. So Imuran and Pyrenethol, also called azathioprine or 6-MP, have been around for decades. We've certainly got a lot of experience using them, and they certainly help many patients. But they do require regular blood tests because we have to look for some potential side effects related to the blood counts in the liver. So we have to monitor people on these treatments. And they have been linked to small increases in risks of some cancer, including lymphoma and skin cancer. Not melanoma, but other kinds of skin cancer. So those risks are small, and often the benefit outweighs the risks. But obviously we have to talk about that with each patient and make sure that we're comfortable that those benefits outweigh those risks. There's also methotrexate to this level. Methotrexate, the thing with it is that the best way to take it, the most effective way we think, is to give it by injection. So a lot of people don't like giving themselves injections, but that is the best way to take methotrexate. Also needs to have regular blood tests done in people on methotrexate. We also give folic acid because it helps to prevent some of the side effects. So those are some options that we can use long-term in people with Crohn's and colitis, and still often do. Obviously, the big advance in the last decade and a half has been this category we call biologic therapy. And why do we call them biologic therapies? Well, I think the main reason is that all these drugs in this category were actually produced by living cells. So the big factories that make them have cells growing in the big broths that are used to produce these. They're made by living cells. So that's why they're called biologic drugs. As opposed to, as was alluded to, things like aspirin, which you can make as chemistry. You can make them in your kitchen on the countertop or a Winnebago in the desert if you want. But you can make those sorts of things with simple chemistry. But because they're these large proteins that you saw that picture of in the last presentation, you can't give them as pills because your body is designed to digest proteins, so they just get broken down, don't get absorbed. So they have to be given by injection, either intravenously or by needle. And they're expensive. Most new medications these days, because it costs so much to develop a drug, it's all these phase 1, 2, 3, 4, 5 trials that you saw mentioned previously. These are expensive things to do, so by the time a drug gets to market, it's often very expensive. It's a very expensive process. So it seems like a lot of money when you learn how much we pay for these things, but the flip side is that they can be very effective. And I would say that these are our most effective drugs for treatment of Crohn's and colitis. So there's a benefit there. There's a potential benefit in saving other healthcare costs like hospitalizations and things like that. And if we get people back to work and get them back to school, improve their quality of life, there's value to all that as well. So you can't just look at the sticker price. We have to kind of figure out whether you get enough bang for the buck. And I think I would make the argument that we do. But there are some issues. Some people can, there's a slightly higher risk of infection, these things that lower the immune system a little bit. So there's a slightly higher risk of that. So we test people for TB, for example, before they go on treatment. And because these are drugs that are made by living cells, you can have reactions to them, little allergic reactions either with the injection or with the intravenous infusion. So you have to watch for that. And because they're also biologic drugs made by living cells, your body sometimes figures out that, hey, this is not made by me, this is made by another living organism, and starts to figure out that they're foreign and makes antibodies to try to reject it. So we have to use some strategies to make sure your body doesn't wake up to that and continues to accept the drug so the drug can still work. But the bottom point is key. the arrival of this class of therapy has absolutely revolutionized how we treat inflammatory bowel disease. I'm not that old, but already in my career, I've seen a huge difference in the outcomes that we saw in the early 90s, say, and that we see in 2014 in people with Crohn's and colitis. It's really just a completely different expectation. So what are the ones we have? Well, the main biologics that we use right now are these three. Remicade on the right was the first biologic to be approved for treatment of Crohn's and colitis, so we have the longest experience with Remicade. But also they are what we call monoclonal antibodies. So they're antibodies that go float around your body and target a specific chemical, which is called TNF. So they go around looking for TNF, mop it up out of the circulation, and it turns out that if you lower the levels of TNF in the body, inflammation in the gut can settle down. And so we have Remicade as the first one. We also, the second one to arrive on the market was Humira. Remicade is given IV, and there's a support program called BioAdvance, as some of you may have been familiar with. Humira is given by an injection subcutaneous, so under the skin, that patients give themselves, and that's supported by a program we call Progress. And then the new one on the market is called Symphony for treatment of just of ulcerative colitis so far, and that's also given by injection, subcutaneous injection. So now we have three options in the same family, which is great, because if people lose their response to one, which sometimes does happen, we've got two more tricks up our sleeve to get people back into remission. All this has been a very positive advance. But there are some changes happening, and one thing you should be aware of as patients and consumers is that these medications are coming off patent, which is arguably a good thing because there can be competition, maybe competition for price, and that's capitalism at work. But it's hard to copy. It's easy to copy aspirin and make generic aspirin. It's a lot more complicated trying to copy one of these big monoclonal antibodies, those big drugs, because they're so big and complicated. So there's a whole debate in our world about how close a copy does it have to be, and how much information we need to conclude that the copy is just as good as the original, just as effective and just as safe. And so that's a big controversy in our area. But regardless, there's already on the market what we call a subsequent entry biologic. That's the copy. Some people call it biosimilars in some parts of the world. It's already been approved in Canada, not for treatment of Crohn's and colitis, but for treatment of rheumatoid arthritis. That's going to be something out there, and I think you as consumers will have to ask yourself the question whether these copies are as good as the original, and if there's a price saving, whether that price saving is worth any risk around that. So again, I'm happy to talk about it later on, but we should be aware that this is coming. There are also new drugs coming, and this anti-TNF category treatment, I say that's been our savior over the last decade, and many of the patients and perhaps many people in the room are doing very well in that class of therapy, but we like to have options. And so the next class of therapy is dealing with what we call leukocyte trafficking. So this is how the white blood cells travel around the body through all the highways, which are the blood vessels, and different white cells take different off-ramps to different parts of the body. Okay, so white blood cell floating around, maybe waiting to go into the gut. That's where its job is. So it will float around the body when it sees the off-ramp to the gut, take that off-ramp, and contribute to the bowel getting inflamed. Well, what these drugs try to do is basically block that off-ramp so that the white cells can't get to the gut in the same numbers, and that the inflammation can settle down. So there's one drug in this family which we think is going to come to the market in Canada early next year. Its chemical name is Vedolizumab, and we think it's going to be called EntyvioTM. It's already approved in Europe and the U.S., and it might be coming to Canada, so we'll have to get some experience with that. But it gives us some more options, so that's why I say there's hope for the future, that we have good drugs already, and we'll have some choice in the future as well. So, drugs. We always keep talking about drugs, right? I know people will get tired of that, but these still are the most effective ways we have of treating Crohn's and colitis. But everybody always asks about diet, and it's a very natural question because this is a digestive disorder. So it makes sense that what you eat must have an influence on how your Crohn's and colitis behaves. The problem is we don't really have a diet which we can say treats Crohn's or colitis, that is, controls the inflammation and makes it better. Lots of stuff out there. There's lots of anecdotal experience that people publish and present, and of course we welcome all that information. But if you look at studies, we really don't have studies to show that these diets really make a difference in the disease. So it's a source of frustration for us as well as I'm sure for you. We really would like to have diets we can say treat the disease. However, nutrition is important. And if you're looking for resources, this is my colleague in Toronto, Hilary Steinhardt, who's written 2 very good books about Crohn's and colitis. And I don't get any royalties for promoting his book, but I think it's a great resource. It's well written. And the one in front, the green one, actually is a diet guide for Crohn's and colitis. Not claiming to treat Crohn's or colitis, but making the important point that you need to have a good balanced diet, you need to maintain nutrition, and there's some foods which frankly are better tolerated by people with Crohn's and colitis to make you feel better. So those are excellent resources. But other things related to diet is you have to eat well. And part of our job is looking after IBD is to monitor your nutrition in various ways. We look at iron levels and B12 levels, and if those are low, they should be replaced. I think everyone in Crohn's and colitis should make sure they have enough calcium and vitamin D in their diet, partly because we have to maintain bone health, but also because there's a lot of interest around vitamin D, which we'll touch on. And there's some diet-related things which have some small trials in their support. So if you're looking for things, you can think about maybe increasing your intake of fish oils, omega-3 fatty acids might help. Curcumin and turmeric, the spice, has some anti-inflammatory effects. Aloe vera is some evidence and some support. I mentioned vitamin D as well. So again, these shouldn't replace, I don't think, the other aspects of your care, but there are other things you can do with diet to try to help. So they're not a substitute for other treatment, but they're a nice complement to other treatment. So vitamin D, quickly, is an important vitamin, and it has a lot to do with the calcium balance in the body. So your calcium levels and how calcium gets absorbed and excreted from your body, a lot of it is regulated through vitamin D. Obviously, we live in a northern climate, and so we have a little less sun than places around the equator. And it's an interesting hypothesis that maybe one of the reasons why you see on that map of the world more red towards the north is that maybe people in northern climates see less sunlight, maybe have less vitamin D, and maybe low vitamin D plays a role in developing Crohn's and colitis. It's not been proven, but it's a very exciting theory that's out there. And also, maybe part of the reason why modern people don't get more Crohn's and colitis is we spend more time inside, office workers, things like that. It's an interesting idea. But the low vitamin D level has been linked to other things like cardiovascular disease, depression, even some cancers like colon cancer. And there's a lot of debate around not only Crohn's disease, but also multiple sclerosis. So again, it's all early stages. None of this is proven. But there's really not much downside to taking recommended doses of vitamin D and a lot of potential upside. So we think it's very important that our patients with Crohn's and colitis either consume a diet that has a lot of vitamin D. 3 glasses of milk a day would get you there. But if you don't like milk or can't tolerate milk, other foods can contain vitamin D, or you can take vitamin D supplements. So I think that's a very important thing. And as I mentioned, a small trial that suggests some benefit in Crohn's disease, but it's very early days, and research is ongoing, and we've been involved with a very small study looking at high versus low dose vitamin D at our center. Other hot topic, I know you're going to ask, probiotics. Right? We think that the bacteria play a very important role. We don't know for sure, but we think that the bacteria play a role in how Crohn's and colitis develops. So maybe if we try to manipulate the bacteria, maybe if we try to deposit more healthy bacteria in the bowel, we can treat Crohn's and colitis. That's where probiotics comes into play. The definition of probiotics is in that first line. These are live organisms that, if you give the right dose, can actually help the host, which is you, the patient, taking probiotics. But the problem is we don't really have very few studies to look at whether probiotics help Crohn's or colitis. So it's very early days. I personally think that the future is very bright here, and that we will learn more about this. And if we had this meeting in 10 or 15 years, we'll probably have a little more specific information to give you. And the nice thing about probiotics is there's very little risk, very safe things. We have a little trouble right now in 2014 saying they're going to actually help you. But they're using a particular one called VSL3 for colitis and pouchitis and Crohn's disease. There are some studies there. Again, not great studies, but they're there, and so it might be a signal. And another bacteria called E. coli Nissl 1917, which has been studied in colitis. Again, not the greatest studies, but there's some hope there, and that more research needs to be done really to try to pursue this. But there's no harm with probiotics. So It's already been alluded to, a lot of interest around, well, if you can't, how can you change your bacteria? Well, you could take probiotics, take healthy bacteria. You could take antibiotics and kill some bacteria and hope the good ones grow back. Or maybe you can just do a transplant, right? Get a donor to give you stool, and that stool has billions and trillions of bacteria, and take that donor stool and put it in your own body. This is actually from New York Times last year, I like the picture, but it's also a story of a woman who had C. difficile, a terrible infection that can develop. And we know that C. difficile can be well treated by stool transplants, fecal transplants. And so this is a story of a woman who donated her stool and saved her friend's life, which is an unusual story, but it's becoming more and more common as we deal with C. difficile. So as Walter said, we can't tell you any of the results from this trial because it's been ongoing, but there is a study we've been doing here looking at treating colitis with the fecal transplantation. And if you stay tuned in the next couple of months, I think you'll see some data released about that because we have finished the trial. So we're still a little bit ahead of schedule. I tried to stretch it out, but I think these are some key points. First, Crohn's and colitis are very common. Second, that our understanding of Crohn's maybe from the outside it seems like it's moving very slowly. We're not seeing big breakthroughs, but there is progress in our understanding of what happens to people with Crohn's and colitis. And we are, I think, just starting to see a new wave of treatments come through. So I think that the future is good. And I think that this idea of timely treatment, so knowing when, trying to learn a little bit more about when to treat and who to treat, who needs treatment early versus who can wait. And this whole idea of individualizing treatment, that's a huge thing for the future. It's not just throwing a standard recipe at everybody, but trying to use some tools that let us predict what treatment's going to be right for an individual so that we can tailor the treatment to that individual. That's really where the future lies. So current treatment is good, but we can do better, make better use of what we have, and look forward to these new treatments on the horizon. And again, that's why I said there's never been a better time to have IBD. The future is indeed, I think, bright. So I will stop there. Thank you.